Hello, everyone. I'm here instead of my colleague Ines Kenyat, who was invited. My colleague couldn't make it because she's currently implementing the new sexual assault reference centers in Belgium, which should be normally accessible for everyone, regardless their legal status. So she has other issues to attend to. So that's why I'm here, and I'm going to talk to you about reproductive health and sexual violence in refugees and migrants. And I'm going to start with a little bit of background information and the definitions that I'm working with, because often there's a lot of confusion about what sexual and reproductive health actually is. To me, or to our research center, sexual and reproductive health is a state of physical, mental, and social well-being in relation to sexuality and the reproductive system. This means that people should be able to have a satisfying and safe sex life, that they should be able to reproduce, feel free to decide if, where, when, with whom, how many times. It should be up to them to decide on that, and this should all happen in a context free of coercion, discrimination, and violence. When we talk about sexual violence, there are also a lot of different definitions going around, and most of us instantly think of rape, but actually sexual violence is much broader than only rape. It's about any sexual act, attempt to obtain a sexual act, or other acts directed against a person's sexuality using coercion. And this concept of using coercion is crucial, since it's something that is experienced by the victim. And it's by any person, regardless of their relationship to the victim and in any setting. This relationship to the victim is also important, certainly given that in many countries, for example, rape in a marriage is not a crime. It's only since 1997, I think, that in Belgium the law changed and that a man could rape his wife, for example. So those are things that have to be taken into consideration too. And it's about, and when we talk about rape, it is defined as a physically forced or otherwise coerced penetration of the vulva, the anus, with the penis, or other bodily openings, or by the use of other objects. So if we're going to look at the behavior or the acts of sexual violence, then we can see that there are different kind of categories which fall under this definition. It can be sexual intimidation, which means that there is no physical contact. Sexual abuse, which means that there is sexual contact but there is no penetration. Attempt to rape means that there's physical contact and there's an attempt to penetration, but it didn't succeed. And then there's rape, which really is with a penetration. In the context of migrants, we should consider two broader terms of sexual violence, being sexual exploitation in the context of trafficking and conflict-related sexual violence. So actually sexual violence which is not motivated purely because of sexual desire, but it's more used as a weapon of war and really to affect a certain community. I've also mentioned some other concepts such as harmful cultural practices, gender-based violence. Yeah, but it falls. Can I be closer? I can be here. Is that better? No? I'm going to do my best to speak a little bit louder. I'm not good at that. But please give me a sign if it's not good enough. So I also mentioned harmful cultural practices such as female genital mutilation, gender-based violence, violence against women, and intimate partner violence. And the reason why I mention these is because these are terms which are often used to refer to, among others, sexual violence. Not only sexual violence, but sexual violence is often included in these terms, but also because they often only focus on women being victimized. And this is a big issue because when I look into the literature on these topics, men are rarely mentioned, and if they are mentioned, they're mentioned as being perpetrators or being victim as little boys, or in the context of torture. But for example, in intimate partner violence, men being victims is often not talked about, and they can become victims. Some numbers. If we look at a study from my colleague Ines Keinert and some of her colleagues from 2012, well, she did interviews with migrants in Belgium and the Netherlands, and she asked them about their experience with sexual violence since their arrival in Europe. So not in the home country, but since they came into Europe, how many cases did they see of sexual violence, directly or indirectly, as a witness of it? And 57% of them said that they had experienced or they were confronted with situations of sexual violence. That's a lot. If you look at the gender differences, we see that 69% of women report having witnessed or experienced sexual violence in a direct manner, which is a little bit more than men. But given the fact that it's that there is a lot of stigma on male victimization, we think that this might be an underestimation. And then if you look at the types of sexual violence that they experience, then you can see that rape is the most frequently discussed, but it's also the thing that comes most to mind to people when you ask questions about sexual violence. So it's always important, if you're going to discuss sexual violence, that you ask about the concrete acts of violence that have been experienced. In a following study, it was a study in 8 different European countries, they saw that there were 3 important findings concerning the nature and the prevalence of sexual violence, being that there was a high prevalence of sexual violence in both genders, and this in combination with other forms of violence. So it turns out that there's a risk factor. If you're victim of one sort of violence, then you're becoming more at risk of being victimized in other forms of violence too. They also saw that cases of sexual violence were multiple, and gang rape was often mentioned. And importantly, professionals appear to be an important part of the assailants of sexual violence. These might be people working in reception centers, but might also be people working around them, or even authority figures. And this is important because sexual violence has multiple and long-term consequences, and there's a limited access to healthcare. If we look at another study, which was done in migrants traveling through Morocco towards Europe, they saw that sexual violence was often considered as a rite of passage, meaning that it's something that just comes along with migration. I think that's a horrifying idea. And so what you can see is that, again, there's a lot of gang rape mentioned, but also other types of violence. And if you look at our little pie, you can see that it was only 16 people who said that there was no experience of sexual violence. Directly or indirectly, it doesn't always mean that they were victims themselves, but traveling through with a group and having heard of someone or seeing someone being raped happens a lot. When we look at what the consequences are of sexual violence, then we can see that they have consequences, that there are consequences on different levels. On the physical level, you can see that there's the immediate consequences, such as bruises and bleeding and so on. But in the long term, it can result in sexual dysfunction, cardiopulmonary symptoms, neurologic symptoms, chronic pain, fibromyalgia, and so on. Psychologically, it's not surprisingly, depression, anxiety, and PTSD are mentioned a lot. Sleeping problems, feelings of shame, guilt, frustration, and hatred. Also an impairment of social support relationships due to having psychological problems or physical problems may also be a consequence and may further decrease their mental health. And then we see in male victims that they also often have questions about what does this mean for their masculinity and their sexual orientation if they have been raped by another man, for example. On a socioeconomic level, we see that there's a lot of stigma and shame attached to being victim of sexual violence, which could lead to underreporting of cases, social rejection, and in some cases even to death, because the community rejects the victim. Okay, if we're then going to look at the consequences of sexual violence, on the sexual and reproductive system, which is my bridge to the following part, then we can see that sexual violence could lead to fistulae, abnormal genital bleedings, severe abdominal pain, cysts, physical limitations, and STIs such as HIV, AIDS, and others. There are also a lot of sexual problems which might be different for men and women. For example, women often report loss of sexual interest, vaginismus, and dyspareunia, where men are rather going to report erectile dysfunctions and premature ejaculations, which are caused by psychological consequences. And then also in the reproductive part, we see a lot of unwanted pregnancies, forced or unsafe abortions, and miscarriages. My colleagues at the ICRH conducted a systematic review and made a report on strategies that could be used to reduce inequalities in accessibility and quality of maternal health care delivery for migrants throughout the WHO European region. And I'm going to discuss their report now. So I'm going to start with a little bit of the background and the methods that they used, and then afterwards I'm going to present the results and the policy options. At the moment that they did their review, 52% of the migrants were women at the time. And I already mentioned the definitions that we use, but just to remind you, we were looking at well-being related to sexuality and looking at ways of improving access to appropriate healthcare services. Okay. When we look at maternal health, we actually talk about health of women during pregnancy, childbirth, and the postpartum period. And actually, reproductive and maternal health has been gotten more and more attention due to the fact that it's been mentioned in, for example, the MDGs and the Strategic Sustainable Development Goals. And what we can derive from that is that there should be an effort to ensure universal access to sexual and reproductive health, including maternal health. We should improve maternal health, reduce maternal mortality, and have specific attention for vulnerability of migrants. You can all find the results of this review in the Health Network report, Health Evidence Network report, which had as the main research question was what intervention and policies work to improve the accessibility and the quality of maternal health care for migrants in the WHO European region. So they did actually a review of both academic and grey literature in Dutch, English, French, German, Russian, Spanish, and Ukrainian. And this led up to the inclusion of more than 400 documents. And what came out of it? Well, first of all, it was very clear that migrants face poorer maternal health compared to non-migrants in this region. And we could see this because there were more induced abortions, caesarean sections, instrumental deliveries and complications, except for lower birth weight and pre-eclampsia. Plus, there was also higher infant and maternal mortality rates. These poorer maternal health conditions were related to risk factors preceding and contextualizing migrant maternal health. As mentioned before, there's there's less access to certain services, among which family planning and contraception. There is also a lower uptake of general gynecological health care. They are more at risk of unintended pregnancies. There's more chronic stress, PTSD, exposure to female genital mutilation and sexual violence, and also the entitlement to care depended on the legal status in many countries. So a second result was that the accessibility to healthcare is jeopardized by problems with familiarity, comprehensibility, acceptability, availability, and affordability. A lot of migrants don't know how to navigate healthcare systems in the country that they're arriving. You should imagine that if you're on the move and you're passing different countries, that you can't know how the system works in every different country. So that's a major issue. And then also the fact that they don't speak the same language as the healthcare providers, and the fact that they don't know how to afford it are huge barriers. And this resulted in, for example, in studies from Kyrgyzstan and Moscow that showed that only 3% of the pregnant women attended antenatal care, and that 82% of pregnant women suffered from anemia, and 23 had a hypertensive disorder. 76 of the patients who were pregnant appeared to be unplanned. In Austria and Sweden, there was also research on this, and it turned out that there was that the fact that the people didn't speak the same language played a major impact. A third result was the fact that there are still no clear guidelines on what quality of care should be, but in all the studies done on this issue, it turned out that at least we should try to be culturally sensitive, and we should not just apply guidelines which work for the general population onto the migrant population. We should always look at what works and involve migrants in the process of adapting the current guidelines in the general population. And then a last result. Recent asylum crisis poses extra challenges in providing maternal health care, but a lot of supportive guidelines and directives have been developed, and there are also a lot of tools and online trainings that you can follow to go and implement things. For example, the MISP is very useful for providing maternal and sexual healthcare in emergency situations. The Semper Forte framework provides us with a training to work gender sensitive and culturally sensitive around everything that has to do with reproduction and sexuality. And then one of my last slides is that there are some policy options identified to improve migrant maternal health, being first of all, that it's important to consider maternal health as part of sexual and reproductive health, and that we should promote and invest in family planning. It's also important, as I've given you the numbers, to prevent sexual violence and female genital mutilation, because these both have a major impact on the reproductive health of girls and women, but also on men when it's about sexual violence. We should also try to align entitlements to sexual and reproductive health care with the human rights, and simplify and standardize the administration, the administrative procedures, because that's a major barrier for a lot of migrants. Inform and sensitize migrants and healthcare providers is also important. A lot of healthcare providers turned out not to be aware of what the current rules were in providing healthcare to migrants who do not have regular status. Also, enhancing cultural competency of sexual and reproductive health staff, including the migrants, should be important. I already mentioned it earlier today. For example, in Belgium, in our general education of psychologists, sexologists, there's never any course about working with people from other cultures. So that's something that really should be get more attention. And then applying minimum standards and international guidelines, improving access and care, and ratifying and implementing the WHO EU strategy on sexual and reproductive health and migrant health and the sustainable development goals and so on should be taken into consideration too. These are some recommended readings, which you can all see. Are there any questions?
Thanks a lot, Lotte, for this very interesting presentation. Is there any question from the audience? Yeah, José Jaime.
Thank you very much for the presentation. You show a slide saying that, well, in the title you put people, non-identified people, and then you put some figures. That means that people non-identified have a higher risk of sexual violence than the others? It's like that. You have you can have this link, direct link.
Can you repeat the question?
Yeah. If you can find in your study that there is a direct link between non-ID card and the increase of the risk for sexual violence.
Well, it is one of the risk factors, but becoming victim of sexual violence and the risk factors towards it are often a combination of several factors. For example, if you have an irregular status, but you have a good social network and there are people who are going to help you, then that might be a protective factor. So it's not a one-on-one relationship, but what we do see is that, for example, having a lower socioeconomic status, not being able to really report threatening situations because you're afraid that they're going to arrest you and deport you makes you at higher risk. For example, one big risk factor, we don't like to hear it, but staying in a reception center is one of the risk factors for becoming a victim of sexual violence. You're also at higher risk of being trafficked if you don't have the right legal documents. So there is a link, but it's not a one-on-one link. It's more like the combination of several risk factors together that makes you more vulnerable to experiencing sexual violence. I don't know if that answers your question.
So do you think if the countries, the hosting country, provide with identification to those people, the risk will be reduced only for this fact? I mean, because here the Greek representative here in the Kalma said that the idea is step by step integrating these people in the Greece life. But without any ID card, how they can manage that?
Well, I think it would be, this is my opinion, I think that would be a first step, because that would also allow them to, for example, get jobs, get proper housing, and actually get into contexts which are more safe and more protective against sexual violence. So I don't think that it will be the major resolution, but I think that it will be a first step in going towards creating safer environments for people and reducing the risk factors.
Thanks. We have another question here in the back. Concha?
Yes, thank you for your presentation. It's very interesting. I would like to just to comment something in regard of sexual violence. It's always an underreported event, so it's really difficult that the victims talk about, because it's linked to the shame, to the guilt, self-esteem, I think that from the audience where we have so many epidemiologists and so many people focus on surveillance, we can also contribute to detect the consequences of these events by putting in the in the symptoms and the syndromic surveillance, for instance, consequences that this kind of violence may affect to the person. So we can indirectly detect these, and we can also contribute to better address health services to these victims that many of them are not allowed to denunciate the event. So thank you.
Yes, absolutely.
Okay, last question.
Thank you very much. Very, very interesting. Can you comment on how, well, two things really. One has to do with how our different cultural bases influence our notions of what constitutes sexual violence and anything related to it. And the other is to what extent, you mentioned the violence against men, violence against women. Are these equivalents, or do we have power differentials related to gender roles and sexism and so on in these in our understanding of sexual violence?
I'm first going to go to the cultural thing. Well, it truly is the case that what's considered as sexual violence differences from one culture to the other. But we see that the consequences are mainly the same, except for the psychological consequences might be different depending on how it's culturally integrated. But if we're going to look at the situation in Europe, then we use the definitions which are used in Europe and in our laws actually. And it's good that you mentioned, because there are a lot of studies which I can't compare on their prevalence numbers because of the different definitions which are used. So it really is an issue in defining what sexual violence is, and that's why we mainly suggest to look at the acts. So did anyone touch you? Did someone penetrate you against your will? Those kind of things, really the behavioral things, more than asking about did anyone harass you. So that would be a suggestion. And then the second question was, could you repeat it, please?
Question.
Men and women.
Yeah.
Yes. Well, there is a difference in men and women, being that, well, the acts against men are often more violent than against women. But also our way of looking at what sexual violence is, or actually violence in general against men and women, is kind of different. For example, if you look at intimate partner violence, which is more familiar in research, then you can see that, for example, if a woman was to slap her husband, we all think that, oh, there must have been a reason for her to do that. It's not so bad, you go girl. Those are the reactions that you hear. But if a man does the same thing with the same impact, he's the bad guy instantly, and it's not okay. So our society has different views on what violence is, depending on the one who is exercising the violence and the one who is being the victim. So for sexual violence, it's definitely going to be the same thing, and that also has an influence on the psychological consequences afterwards. The fact that women are more often considered as being victims means that they have more access to healthcare and to support from the people around them. A lot of men who become victim should keep their experiences secret because they fear of being pushed out of their social networks if someone would learn about it. So the disclosure of experiences is very different for both sexes. And then there's still the issue of transgenders, which is even more complex, and those of other sexual orientations. So it's very clustered, but we know that there are differences.
Thanks. We have a very... No? Okay. Thanks a lot, Lotte, for this presentation.